everyone.
Let's start. You're on mute. Right, welcome everybody. It's really exciting to have everybody here for this inaugural meeting of APEC International. This is a forum that we've been trying to get together for some time now, and following all the issues with COVID, but I'm really excited that we've all been able to join when we have hundreds of people from all over the world who've signed up to listen in or to watch this later in video. So I wanted to just spend 10 minutes outlining what APEC International is all about, or what we would like it to be all about. And then I'm going to pass on to some really fantastic friends, colleagues from all over the world who are going to share some of their experiences around pre-eclampsia. I'm just going to share my screen now. So first of all, what is APEC International? So this sort of roughly this time last year, a group of us who'd been doing research together from South Africa, Zambia, Zimbabwe, India, were together in Livingston in Victoria Falls. And we really joined up our thinking about what APEC International might look like. It was pretty clear to us that this problem of pre-eclampsia was a truly international problem, and more so the place where it really matters seems to kind of been left out on the research agenda, and the place we're going to make a big difference perhaps needs assistance. And there's no doubt that I've learned a huge amount from my colleagues working in the challenging parts of the world, and we really wanted to share this. So this is a small group of us. You can see Kath Wilson there in the blue dress, who's actually from South Africa, who's the coordinator of the website, and the others, some who are talking today that you will meet later. But what is the mission statement? So the mission statement that we came up with, and we're all ears here, because at the moment, APEC International is a sort of blank sheet. We want it to evolve and be created by everyone at this meeting, and for you to invite others to get involved. But essentially, it is a web-based platform aimed at reducing maternal and perinatal health inequities related to preeclampsia and the hypertensive disorders. Basically, we want women who have these problems to do better. We would like to provide educational materials and signposting to existing resources. So we don't want to reinvent the wheel, but we want to help people access the things that matter quickly. And this will improve education and awareness in the area. And we would like to facilitate reciprocal learning across the different global communities. And this is where we all come in, and we all should get involved to improve outcomes for women and babies. So that all sounds well and good, but actually, as I said, it is a blank sheet. And today, in the next 2 hours, we want to share with you thoughts from some of our colleagues who have been dealing with it and thinking about this problem for some time, and also try and build an entity here that we can move forward in the way you want to. So really, this is the beginning. And obviously, if it works, then it can expand and evolve. And this is what, at the end of today, I'm going to walk you through the website as it stands at the moment. One of the reasons why I think that this is such an important area is because of these inequalities. If you actually look at the impact of mothers dying from preeclampsia around the world, it's no doubt that the biggest problem is around places like Africa and Asia. And yet all the research goes on in sort of the global north, where it's not always relevant or necessarily focused on the problems that exist. And that translation between the two is very challenging. And we know the outcomes can be very good in preeclampsia with the right care. I'll just give you an example here of some of you will know about our cradle device, which we've designed to try and be suitable for low-income settings, with simple charging and with traffic light systems that anyone can understand. But here's a picture from a woman who had an extremely high reading in Sierra Leone, who actually became incredibly sick and went blind an hour or two after this reading. But everyone with their sophisticated machine thought her blood pressure was actually not too bad. This is really an indication to me, it's an illustration, just an anecdote of how severe the disease is around the world, and where people need the care the most, they are perhaps not getting it. And so when we've been working with our many colleagues around the world, we've realized there's a lot of reciprocal learning and actually a lot of sharing that we can do. And I'm hoping that APEC International will, however, make this bigger and more sustained. I'll give you an example of the research we've been doing. Here's some research that was done by one of my PhD students, Tanya, who's talking later, showing that women who have eclamptic fits, and this is over 2,500 women in one of our studies who had eclamptic fits, and that is the biggest set of eclampsia in research ever. And when you do research in challenging environments, that's when you see the morbidity. And we related the chance of eclampsia to in-house pollution, for example. So here was a completely novel new finding because we go out there and do the research. So one of the things we want to do is promote research as well. Anna Martin, who's helped put together this meeting today, actually sent you all out an MCQ. I wanted to share two questions with you just to illustrate a point. Actually, the MCQ was quite challenging, and I would encourage you all to do it. We had about 30 respondents, and I'll show you the link to it. But here was a question: maternal mortality in pregnancy related to hypertension is about 100 times greater in Africa compared to the UK. Now, that was a bit of a trick question because it's actually 500 times greater. the reason why this is so important, we haven't got cure for preeclampsia in the UK, but we are lucky enough to have a health system that we see people regularly, and we are able to act promptly and quickly. And it's a real lesson to me, but I think with the right care, we can make a big difference. The other question, so this basically shows that we have only 1 in a million women dying, whereas roughly about 1 in 2,000 women die currently in a low income setting. And I think that it's a quick win really for making a difference. And we can discuss some of these issues later today. Another question which people actually got wrong, which I thought was worth showing you, is maternal mortality in pregnancy. Pre-eclamptic deaths are principally prevented by giving drugs. Now, we know that antihypertensive mag sulfate are incredibly important drugs, but very few interventions have actually been linked to saving lives. And it's probably other things that save lives. And for example, here, delivering people in a timely way and identifying them is perhaps a bigger lifesaver. So that just sort of illustrates what I'd really like you to do is kind of answer these questions so we can get some feedback about the current state of knowledge. We actually have 2 winners for our MCQ, and they are both from India, and congratulations. So we will get hold of you and try and send you some equipment as a prize. But if the rest of you like to do the MCQ, we will follow up. And here is the sort of link, which we will email to you as well if you would like to do that. It also takes you to one of the films on the website. So I'm going to stop there and hand over to the next 2 speakers, who I'm absolutely delighted are able to take part. I'm going to stop sharing there. But so we have 2 speakers in the next 20 minutes. Koiwa is a phenomenal woman, a really brilliant CV, which you can read, and I'm not going to say any more because she can tell you about herself, but she was a founder of APEC Ghana. That actually is a sort of real exemplar to the sort of thing that we would love to have all over the world. And because that's such a good exemplar, she's very generously given her time to come and share with us some of her thoughts around APEC Ghana. APEC doesn't belong to anyone. It's an action on preeclampsia charity. It's been going now for nearly 30 years in the UK. There are people using the name in Australia as well. But I think Ghana is a phenomenal place where we think APEC's work could have a really good impact. So I'm going to hand over to Koiwa, and then when she's finished, Marcus, who's the CEO of APEC in the UK, will also share a little bit of his experience. I will talk to you later on today, and this video, this will all be recorded and you can watch it again later. Koiwa, thank you so much for joining us today.
Hello, good afternoon, everyone. I hope you can all hear me. My name is Koiwa of Oswapia. Nice to meet you all from all over the world, and greetings from Ghana. In Ghana, in my local dialect, we say Akwaba. So welcome to this to this inaugural meeting. Indeed, I'm privileged to be part of it. I still remember 2017 when I first contacted APEC-UK through Marcus with the intention to, start the APEC in Ghana. Before I move on to my presentation, permission to share my screen, I would like to just give you an antidote of the situation in Ghana when it comes to excuse me, please, sorry. Give me a few minutes. When it comes to hypertensive disorders in Ghana and what is happening here. And so I'm just trying to share my screen so that we can just watch this video shortly. Sorry for delaying. Okay, so this is a short documentary that was taken 2018. I just want to give you just a bit of it. It will give you an insight of the situation in Ghana and the inspiration behind APEC. So kindly confirm if you can hear the audio when I start playing. Thank you.
I didn't cry.
Did you touch the body?
I didn't touch the body. I just wanted to confirm that indeed she was dead. And I got the confirmation.
In Accra, the nation's capital, pre-eclampsia kills more women than any other maternal health complication. Accra also records the highest number of maternal deaths in Ghana. That's according to the immediate past regional health director, Dr. Linda Van Otu.
They go in to deliver with very high blood pressure level. Some of them, when they are pregnant, before they became pregnant, they did not have blood pressure or hypertension. But through the pregnancy, you find that the blood pressure goes very high. So high that some of them can even faint. And then some of them, unfortunately, die. And once the baby is inside, when this happens, then the mother loses her life and the baby also loses his or her life. We have had blood pressure readings that are unimaginable.
Like?
One of them went to as high as 300, over 180. And that is unimaginable.
Kwewa Kweilabi Ofosuapia survived this. She lives here in Accra with her husband and their only child. But for pre-eclampsia, she should have been a mother of 3 by now. She narrowly escaped death twice.
I had attended antenatal for 27 good weeks, a whole first degree holder. I was as ignorant as anybody else. Even my mom, who had it, couldn't, for whatever reasons, didn't tell me, even though I knew she had lost some babies. The nurses or whoever who saw whatever sign, because it just didn't start that night. I had the symptoms, headaches, you get big unnecessarily, but nobody said anything. And so it's ignorance that killed my baby. I'm lucky to have survived eclampsia because it affects the brain. It just, some people just don't survive. And when they do, they are like,
okay. So that is the story behind pre-eclampsia in Ghana, behind APEC in Ghana, and why we founded APEC. I'm a 4-time survivor of pre-eclampsia, eclampsia, and HELLP syndrome. And out of 4 conceptions, I currently have only 1 child. And that is the inspiration behind APEC, because after surviving it, I could find no support group. I couldn't find anybody that I could speak to, and that is how come I reached out to APEC-UK and APEC Australia before we initiated this movement in Ghana. So our journey so far, as I've already shown you, it was through a traumatic experience that APEC Ghana was formed. There's a popular saying here where they say experience is the best teacher. It is indeed the best teacher. So APEC first started as a movement. It was formerly known as GAPEC, that is Ghana Action on Pre-eclampsia. And as part of the movement, we had to share our story through media. And then by sharing our story through traditional media, we had other women who joined, and then we started, creating awareness about it. And then we officially commemorated World Pre-eclampsia Day in 2017. Before then, nothing had been done in Ghana on it. The main objective of APEC really is to inform, advocate, create more awareness about pre-eclampsia within Greater Accra, which of course there's more incidents of mortality rates related to pre-eclampsia, and the other regions. In Ghana, we currently have 16 regions, and so that is our purpose, to educate, inform, and advocate for better and quality care for high-risk women. We also have the objective of partnering with research organizations to be able to come out with, research interventions on how we can deal with the menace of the condition in Ghana. And also the third objective is to provide support for those who suffer it, whether by losing their child or whether by losing the mother. So most of the time in this part of our world, when it comes to patronizing the services of a clinical psychologist, it is something that is not encouraged. And so the whole aim is to be able to encourage women who have that traumatic experience to get the mental health that they need when they need it. As I've already stated, our aim is advocacy, awareness, engagement, and better care. We have done this through, community sensitization. We also took advantage of the virtual platform during the COVID time and organized patient learning series webinars. We also saw the need that even the health practitioners have to be educated, because somehow, even though they know about the condition, or at least we, from the patient's angle, we assume they ought to know by the training that they've had. Somehow there's an issue when it comes to communicating it with the patients. So we realize that there's an obstacle, and so we as an organization try to organize workshops to be able to encourage them to do the needful to communicate to patients when they need to, and also build their knowledge on how to manage the conditions. We also engage other government stakeholders like Ghana Health Service, and then the other Medical and Dental Association and Nursing and Midwifery Association, all to be able to take priority when it comes to developing policies or developing programs to deal with the menace of pre-eclampsia, eclampsia, and HELLP syndrome. So even though we started as a movement, in 2018, we officially became a legally registered NGO, and this slide is just to show you how we work in terms of organization. So even though I'm the founder, it's not just me, it's a team working together. We have the Executive Council, which is made up of the Board of Directors. Then we have the Research and Scientific Committee, which deals with issues of research and science. And we have the Editorial Board, which deals with issues, publishing newsletters to the population. And then we have our regional coordinators. These are one of the most important pillars in our structure, because it is through them that we are able to reach out to the local. So we have 16 regions in Ghana. If you were in the United States, you say you have 50 states. I'm not sure how it works in UK, but then we have 16 regions, and so we have a representative in each region and help us to reach out to the local community there. And then we have the general volunteers, and then of the administration. So where have we been? What have we been up to? As I said, since 2017, after launching APEC, we then organized sensitization programs, capacity building programs. In 2018, in commemoration of World Pre-eclampsia Day, we did a street outreach campaign. On this day, we were able to get the First Lady of the land to be able to add her voice to the call for us to pay attention to the condition and do something about it. And then, of course, in 2019, we initiated the Pre-eclampsia Scientific Conference, of which the third one will be happening tomorrow, and the same for 2020. And then we've had several stakeholder engagement talks. And of course, we are also currently, in terms of research, currently a member of the SPOT Impact Study. SPOT stands for Severe Pre-eclampsia Outcome Triage, Adverse Outcome Trials. And their whole purpose is to be able to improve the care of women who are at high risk of pre-eclampsia. We also engage very well on the social media platforms and traditional media. When I say traditional media, I'm referring to the national radios and the national TVs. So this is just a pictorial view of what we have been up to in terms of past events. And we recently had our patient learning series for this year, and that is what is at the far right corner. As I've already mentioned, we are part of the SPOT study, which is a very good project, which is currently ongoing in Ghana, and it hopes to improve the outcomes of women who are at high risk of HDP, that's hypertensive disorders in pregnancy. We are also, as I already stated, currently liaising with other government hospitals to be able to obtain database, because one of the things we've been able to identify is that there is no sort of primary clear database on the prevalence of, of incidences of, pre-eclampsia and eclampsia in the country. And so as an organization, it's one of our goals to be able to obtain our own primary data and this is what we are going to do through, or this is what we are going to do through our regional coordinators at the various regions. Currently, out of 16, we have 11 regional coordinators, that will say regional representatives, and almost 100 volunteers who help us to champion the cause. And so for future projects, of course, we are going to continue with what we do, but then we are going to take advantage of what we call the mass texting awareness project. So in this part of our world, we have a lot of people who have phones, but then they don't have Android phones. And so when you're using the social media platforms like Facebook or WhatsApp, and you are sending your messages that they don't get them. And so the whole idea is that even though everybody has phones, every phone is able to text or do a call, but not every phone can do WhatsApp, Facebook, and any other. And so we are going to take advantage of the normal texting platform to be able to send, awareness messages and educative messages to our targeted group. And then, of course, in the future, we also hope that we believe that the issue of pre-eclampsia can be dealt with to a large extent if women can take charge of their health. And that includes being able to, monitor themselves when they are home. And that is why there's the CAF project with the intention that we'll be able to, other than supplementing and helping the health facility with, blood pressure machines, but to also be able to empower the women, to be able to, monitor themselves if they are not attending antenatal clinic, but they are at home. And then we'll continue with our community drive and jingles by working through the local assemblies and, of course, our educational seminars as well. Really, the ultimate vision at the end of the day is to ensure a nation where pre-eclampsia no longer threatens the lives of mothers and babies. As I said, it is no good news, it is no good feeling when you have to go through almost 9 months of pregnancy. In fact, for me, I never got to 9 months. I always get to 7 months. My only surviving child I had here at 37 weeks. But right after 7 months, everything just went helter-skelter. And then the outcome has always been, not good. And so I do not want any woman to be able to go through that too many times as I have. Even if I'm the worst case scenario, there has to be some sort of intervention so that we are able to have at least a healthy pregnancy or minimize the adverse outcomes. And so just to thank those who have been with us since 2017, Sport Study, the Greater Accra Regional Hospital, that is the regional hospital in Greater Accra, and Accra is the major capital of Ghana. And then, of course, SENCOD, that was the legal organization where I was when I started the movement, and they supported. And of course, APEC-UK, and then UNFPA and Nursing and Midwifery Council. And so this brings me to the end of my presentation. And if you want to contact us for discussion to know more about us, what we do, since we have a limited time for this presentation, we will definitely would love to hear from you. And we are honored to be part of APEC-I. Thank you.
Well, good afternoon, everybody. Thank you very much, Koiwa, for that wonderful presentation, and fantastic to hear so much about what's going on in APEC Ghana. We've been hugely pleased in the UK that we've been able to engage with you and work alongside you. And it's been a tremendous, tremendous result that you've had. But I did just want to spend a few moments this afternoon just talking about APEC in the UK and what we've been up to, so that you have an indication of where we can go. Now, it's through no skill of mine that APEC has been going for nearly 30 years. It's our 30th anniversary next year, which we're very much looking forward to celebrating. But we're very proud of what we have achieved during that time. We've worked with Andy, Anna, and the team on today, and it's been a great pleasure, and we are delighted that you are all here today. And I can see there's over 70 people currently engaged in this meeting. APEC was set up 30 years ago. It was set up by Isabel Walker and Chris Redman. Izzy was a sufferer of pre-eclampsia. Chris Redman was a professor at Oxford University. And it was there for patients, about patients, and to make life better for women who have had pre-eclampsia. That was very much what we were here for. Now, these days, we're a little bit more mature, a little older, a little wiser, and really our work splits into three areas. That is support, education, and research. On the support side, we are there to support patients, support sufferers, and that is our principal aim, to make sure that they have access to information, they have access to us, they have access to good advice. And we do that through a helpline, through our social media, through leaflets in hospitals, and a whole host of other things on top of that. Education remains our second priority. We do that in terms of we run study days for midwives. We have a fantastic resource, a wonderful teaching resource, and we will be launching a new part of that this weekend for World Pre-eclampsia Day, which will be specifically for GPs. Our current training is aimed at midwives, although it's been undertaken by over 2,500 healthcare professionals in 47 different countries. So we've done a good job on that. And you can find more information at our website, apec.org.uk. Finally, the area that we are increasingly involved in and heavily involved in is research. We can't cure this condition on our own, and the voice of the patient within this research is incredibly important. So we are currently involved in over 15 trials, which are incredibly big to the incredibly small. So we're looking at all aspects. And from the research point of view, what we're looking to do is to provide that little bit of extra knowledge, that little bit of a piece of the jigsaw, because there isn't going to be a magic bullet with pre-eclampsia. It is always going to be something that we need to continue to work to find all the parts to it. Now, I'm coming to the end of my time with you today. It's been a real pleasure to talk to you, and I'm looking forward to the rest of the meeting. But it's now my absolute pleasure to hand over to Professor Lucy Chappell, who I believe is going to be taking over for the next discussion part of the meeting. So, Lucy, I'll hand over to you.
Thank you very much, Marcus, and it's fantastic to be at this meeting, which represents so much hard work from many people, and really just the start of the journey. Apologies that I've come from another meeting. So we're just going to have a bit of time with a few panelists just to consider some of the current challenges and the ways of moving forward. So I can see Prof. Walaka, thank you very much, and Josephine. Can I see Josephine on here? Lovely. Hello, Josephine, Mitty, and I can see Sarosh. Hi, Sarosh. And Dr. Ballard, I can see. You might want to pop your video on if you've got bandwidth. And Betty Sam, nice to see you there. So a great collection of people who are so immersed in this to have on. And so I thought that we would just do just a bit of discussion about what some of the current issues are. So I wonder if I could turn to Prof. Walaka, obstetrician in Zambia, professor and chair of the Department of Obs and Gynae at UTH in Lusaka, and with a wide experience. Prof. Walaka, you and your teams have got one of the lowest mortality rates from hypertensive diseases in Africa, despite the many challenges of your environment. Can you tell us a bit about what you think that your success is down to?
Thank you very much, and good afternoon, good morning, everyone, if at all. So we've come to realize for a very long time that the causes of maternal mortality in our environment are the same for many years, and these include hypertensive disorders, infection, and the bleeding. So we've tried to prioritize the management of some of these causes of maternal mortality. And what I mean by prioritizing, we've done targeted training in emergency management of maternal and newborn care. And we have developed an abridged curriculum that targets the main causes of maternal mortalities. So all staff working in the maternity units are taught how to manage women with these conditions I've mentioned, in particular the hypertensive disorder, the pre-eclampsia. We make sure that there are protocols all over in places where women are delivering. And we also conduct drills. To a large extent, we also ensure that they stock up of life-saving drugs such as magnesium sulfate and hypertensives, and also ensuring that BP machines are provided up to a certain effort that we can manage. So with these interventions, we think that would be the explanation why we're having some better outcomes.
So that's interesting. You're talking about a very multifaceted, the training, the equipment, the health systems, all of those areas, all contributing to making that difference.
Yes, please.
Lovely. Can I come on to Josephine? Josephine, you're a midwife in Zambia, and you're one of the research midwives involved in the Cradle 4 study. Can you talk about what do you think are the quick wins for a midwife in managing women with pre-eclampsia, given the high workload that you have? What do you find has been really helpful?
Thank you very much. I'm Josephine. I'm one of the senior midwives based in Lusaka, Zambia, at the highest institution referral hospital. I've been very, very much active in midwifery and clinical practice and research. And just like Professor Valika has said, I've been involved in so many trainings concerning obstetric emergencies. And we came up with, I was one of the champions of a bridged EMOC. I worked with Professor Valika, and we trained quite a number of cadres, including the midwives. Then we had to identify some mentors in other hospitals, those that can mentor the midwives, especially those that are coming on board, the new ones, those that are just training. And apart from that, just at the facility level, we could conduct some drills, like he said, and then we are working as a team together with the doctors so that we are able to mentor the midwives and the doctors that come, because these doctors, they keep on changing as they come. They'll change the units, others will get transferred, then you have the new doctors, the nurses on board. So these trainings, they keep on going and going on. And then we also stick to the standards by referring to the protocols which are displayed in the institutions. So basically, it's all about the trainings and the mentorship programs that have been laid since the time of abridged EMOC up to now. And apart from that, yeah.
Please go on. No, do go on.
Yeah. So apart from that, we are also communicating with other midwives in the health facilities. Since I'm based at the referral hospital, the highest referral hospitals, we have basic facilities where we've identified some mentors. We've continued mentoring them in different forums, like WhatsApp groups and even just on phone. So we keep communicating and doing the drills.
And Josephine, Isabella's put a really interesting point in the chat, which is about midwives being trained and supported to initiate the treatment, say in the peripheral centres, as well as the, sort of the work in the tertiary levels of care. Have you done some work in those sort of more peripheral community settings?
I must confess that is one of the gaps that we have identified. It's like we've done much work in the health facilities, and not much work has been done in the community. And that is what we are lacking, because this problem seems to be more in the community than on the health facility. So there is need for awareness in the community and community participation, meaning that we need to identify some support groups, safe motherhood support groups, so that there's linkage between the health facility or the health professionals and the community also. And this is going to bring awareness to the community. So nothing much has been done on the part of the community, but it's like we've focused much on the health facilities and the tertiary hospitals.
Well, Josephine, we all have to start somewhere, and it sounds like you've done a huge amount at the health centre level. Our work is never done, Josephine, so it sounds like you've got plenty to keep you busy for the next 10 years as well.
Yes.
But thank you, and I think it just shows the importance. It comes back to the teamwork that Prof. Walika and you are both talking about, and that is so essential to making a difference to the mums. Can I come on to Sarosh? Sarosh, lovely to see you. Can I ask about the lessons from your work in Haiti? And just sort of from having listening to what we've heard, and how does Haiti, where are the similarities, but also where are the differences for that setting in particular?
Yeah, so thank you very much, Lucy. Nice to see you as well. I hope everybody can hear me.
Yep.
Okay, great. And thank you very much, Marcus and team, obviously, for doing all this great job. And thank you for inviting me to this panel. So Haiti. So I actually got involved now almost several years ago, just to kind of, and I know there's such great data from other countries as to what's the prevalence of preeclampsia, what's the, for example, what's the rate of maternal mortality, IUFDs and things like that. And it seems like Haiti did not have any data around that. So some of my initial work, and it was just really just through friends that I got there and started working in this hospital called Hospital Albert Schweitzer. And turns out, so Haiti has, I would say, quite higher rates, and even there's much less data, but I found that the rates of preeclampsia, eclampsia, maternal mortality, neonatal mortality was actually, fetal mortality was very, very high, pretty similar to, I would say, in Africa. One thing that I would say I found and I haven't been back there for almost 3 years, and I haven't seen any literature coming out from there either. I would say one of the dissimilar things that I would say even now, just listening to you guys, is I found that there was not much systematic approach to management of preeclampsia, or just having organizations that are working against this obviously deadly disease. So that would be kind of my one take about Haiti would be that I tried working on that a little bit in terms of, and I would 100% agree with Alice and Lucy's that it has to start somewhere. And in my mind, starting it at the hospital level so that you can standardize all your management protocols. You can always have access to, medications that are life-saving in terms of antihypertensives and magnesium, and then reaching out to the community. So I would say that I would hope maybe there was an APEC in Haiti. That would be fantastic if you can actually find somebody there. I found smaller organizations there and people and doctors and working there, but not, at least in that hospital, an organized effort against preeclampsia.
Prof. Walika, did you want to come back on that?
Would you be a bit more specific? Sorry.
In terms of, so when I went there, we were actually the first study that we did there, and I went there as a, obviously I work in the United States, but I went there with a couple of my students just to collect data, what was going on. And we collected data for over a course of 2 years to look at the prevalence of preeclampsia, the rates of antihypertensive use, rates of postpartum hypertension, rates of maternal death, abruption, and any complications related to preeclampsia. So one thing I can tell you what I found was even the data recording was not perfect. So they were still doing it on paper. It was really hard. So there was like not a standard set of data that everybody gets in when they come to labor and delivery. There were no standardized protocols. So education is something that I did there for 5 years in terms of, like you guys are saying, every severe hypertensive has to be treated, in X number of hours with Y number of medications. So some of those things that I think are really like basic bed for management of preeclampsia was sometimes not perfect.
But I think also that's reflecting the comments in the chat about, the protocols being visible and consistent. We've got really good sort of international or protocols across many settings, and it's really about making them visible and implemented into the settings that people are working in. Can I come to you? Yeah, go on. Yes. Sorry, Sarosh, you go.
No, Dr. Walika, we can talk later, but I mean, even in here where I practice in Chicago, the maternal mortality is actually among African-American women is very high, even among United States. So there are like same principles. I think what Alice was talking about, it's, appropriate protocols that are visible and education for all care providers. And I love the idea that the midwives should be part of this guideline development, because they are really, at the end of the day, are going to their care providers. They're going to implement, obviously these. So yeah, same principles apply here too. Education, access to medications and standard protocols for management of hypertension.
Can I come to you, Betty? Betty, you're Betty Sam, midwife in Sierra Leone, and you've been involved through the Well Body Partnership and the Ministry of Health. Can you give us a flavour of your experience with the cradle device in Sierra Leone and how that's impacted your care for pregnant women? You might just need to come off mute. How's that? I can still see you muted. I don't know if I can unmute from here. Betty, I'm going to come back to you in a moment. Just while you're sorting that, can I turn to Dr. Ballard? Dr. Ballard, oh, sorry. Okay. Go on, Betty, you're good to go.
Okay, thank you very much.
No problem. So we're just sort of thinking about the cradle device and how that's worked.
In 2020, 2019, 2020, we had this launch of the device itself in the country. And it was a big launch with stakeholders, especially the Ministry of Health, which is the government entity. And so we had a buy-in with several engagements so that they would see the need to have this cradle device integrated into the general care, and that went very well. Although we had the hitches, with lockdowns, travel restrictions because of the corona, but we managed because of the big buy-in from the government. It was easy for them to support the program. So what have we done with the cradle device? We've trained. I have heard people talking about, other presenters talking about education and training, capacity building. So far, we target the cradle device targeted 8 districts within the country. We have 16, but 8 districts will be started so that we'll do it piecemeal. And 639 facilities we are targeted. Up to now, we have distributed 2,800 devices across these facilities. And for training, we have initially targeted 2,000 health workers, but we are able to train 2,698 health workers across these 8 districts, including pre-service institutions, so that we can get the faculty. What has been the successes? So we have had success stories about improvement through the cradle device, improvements of early recognition by midwives, prompt and adequate action in terms of either managing the woman at their facility, or prompt referral, so that the woman will get to the CMOC facility for care. So this has been a huge success. And because of the buy-in, the Ministry of Health has agreed to integrate the use of the device and the training into the EMOC, existing EMOC training, so that the cradle device itself does not stand bone alone. So that it's
And Betty, I'm very struck by what you're saying about the Ministry of Health. Can you say, why is it, how has that buy-in been achieved?
So the device came in at a time when there were so many gaps with availability of blood pressure monitoring machines in a lot of the facilities. So because of that, and they knew, because pre-eclampsia is one of the leading causes of maternal, obstetric emergency, and also maternal death and stillbirth. So with those gaps and challenges and the absence of blood pressure monitoring device apparatus within the facilities in the district, the Ministry of Health easily bought in, had a buy-in into this program, and they supported, even when there was a district lockdown, travel was difficult. Everybody was able to engage the ministry to have travel pass to go to the different districts up country to do the training.
Yeah.
So there has been a very huge buy-in.
So sometimes it just seemed to have landed at the right point, and sometimes we have to take those
at the right time. The device came at the right time with the challenge of having device, and there are a lot of women dying. Some women were not coming to the facilities because of the corona.
Yeah.
And so we are able to have radio discussions, encourage outreach activities or strengthen outreach activities for the uptake of service to improve for these women.
So lessons that can be learned by many settings. I'm just going to come to Dr. Ballad. Yeah, you're an obstetrician in a large hospital in India, and I just wondered if you could talk about how you share best practice in a country that's got a really large population and many centres. How do you go about getting consistent care in that context?
Thank you very much, Lucy and the APEC team. Can I share my slide and speak? Is that okay?
I think you can. I will need to see if you've got slide sharing, or if you can just talk to it.
Yeah, thank you. I bring greetings from our institute. The question you asked is sharing the best practices. There are 4 ways we can suggest, being in a teaching institute, as well as worked on some of the community-based studies like CLIP and the Cradle. See, we can bring the change of the best evidence which is there through different meetings, groups and forums, as well as by different modalities. It needs to be inculcated in the medical school itself so that the practice becomes easy for the later generation. Secondly, we have a professional bodies like FOXI, which is one of the largest OB/GYN association, and also each state has its chapters, and this definitely can bring forth to the practitioners. And most important is the consultant level and at the specialist level, the care can be all right. But to come to these levels, there has to be a proper guidelines and implementation, which are there in the public sector, but they need to be implemented. For this, we need to have the proper training of this and conveying of these best practices to the various healthcare workers, be it from the lowest level to the highest level at the tertiary care doctors. And also, most important is these best practices evidence must go to the community, and that is through community awareness. To create that, we need to have community educations, and which we have done in our earlier studies, and that community engagement and the community education plays an important role, apart from educating at every level and updating at every level by every consultant, every practitioner, and at the field staff and the community plays an important role to share the best practice. Lucy, is that right?
That's wonderful. And what I really like about that slide is that it happens to have drawn in a lot of what the other panelists have been talking to. And I think Sarosh has been posting in the chat about that sort of integrated approach. There's been a real theme about we've got the guidelines, and it's really about how to disseminate them and implement them. If you don't want to stop sharing slides for a moment, and I just want to sort of throw a question open to all the panel, which is to say, if you could change one aspect if you could do one thing to improve pre-eclampsia care in your setting, what would it be? What is your ask at the moment? Who wants to take that question?
Well, a code to start with.
Yeah, do.
Yeah, so one of the challenges in our environment here is that most women present for antenatal late. And as we heard earlier from Josephine, also the community interventions have not been really there. So one of the first things to do would be to provide health education to improve the health-seeking behaviors of our communities. This has received very little attention. So that would be the starting point, to encourage them to start antenatal early, where they can be taught about the dangers of hypertension, and that they could come to the hospital with measurement of BP. We could pick up this patient early, and to some extent, the starting treatment could prevent some of the complications that they go through.
I think that's really important, and it speaks to, I think, what APEC International are doing in terms of seeking to empower the women as well as the healthcare professionals. It's not them and us, it's got to be that team effort, sort of, and that multifaceted effort, and that working with the women is going to be one important way of achieving that. Dr. Ballard, did you want to come in on that?
Yeah, the one thing, if we want to bring change, is that we need to have effective antenatal or prenatal care. What I mean by effective antenatal care, we should have a protocol-based antenatal care. As it should start with the preconceptional care. We should have the prediction models. Prediction model need not be all that which is required for the biomarker level. We can have a simpler risk assessment, maternal risk factors, plus the mean arterial blood pressure, which the device which we have used from the MicroLife itself can bring. Second trimester mean arterial blood pressure with the maternal risk factor. If we calculate this, and we can categorize whether they are high risk or low risk, and their frequency of visits, and this awareness need to be created within the woman and the community, so that they themselves will come to the care better, and the lower health cadres must be created awareness about this and timely referral.
Yeah.
So most important is we need to create this awareness, and we should predict this, and that prediction will tell us the high risk and low risk. And that way we can definitely have that. And even in the institutes, protocol-based management, that will prevent many deaths and also prevent perinatal deaths also.
Sarosh, did you want to come in?
Yeah, thank you. Lucy, do you mind if I share one slide?
Please do.
Just in terms of what I would, so sorry, this is my.
Oh, we get to see your desktop.
And I know, it's like crazy. I don't know, can people see this graph here?
Yep.
Okay. So I think if you ask me a little bit, I know we didn't talk about, maybe this is a little futuristic. I know we didn't talk about new things like biomarkers, or I know somebody wrote in the chat about the peers model. If you ask me that, how do I look at, and a little bit in lines of what Dr. Ballard was saying, I also personally believe that the prenatal care has to be a little bit more of this personalized medicine, whereby at some points during your pregnancy, you have to risk stratify. And here, I was writing about how biomarkers could be used for risk stratification, but you could use peers model, you could use blood pressures, whatever you're trying to say. I feel like at some point in the pregnancy, it has to be standardized, like Dr. Ballard was saying. And this is more in context. I wrote this paper for Haiti, and to stratify these patients into high risk, where the patients then can be transferred to an appropriate health level facility, to the providers who have appropriate knowledge. And then the low risk patients could be delivered in community hospitals, or appropriate for their care. So if you ask me one thing, if I would change about pre-eclampsia, I would say that I'm hoping that in near future, we will actually change the model of prenatal care a little bit, the way we are providing prenatal care, and stratify our patients in at all levels, maybe at first trimester stratification, maybe at 28 weeks we stratify them, maybe at 32 weeks we stratify them, and continuously are trying to move patients where they can get appropriate care.
Yeah, I think that's, there's where do we want to get to now, but we've also got to carry on being ambitious. I'm going to come to Betty and Josephine. Midwives are the cornerstone of our antenatal and pregnancy and postnatal care. Josephine, what's your ask for the next 5 to 10 years?
Come again?
what would you like to see happening for the next 5 to 10 years? What would really make a difference?
I think what would make a difference, like I emphasized on the first discussion, is community participation. Yeah. Yes, our community, I think, has been on a passive, more of passive than active.
Yeah.
So we haven't done much work in the community. So what I would want to see as an improvement in the next 5 years is to engage the community. We have to bring awareness. It's like much of our concentration has been in the hospitals, but this is the problem that is coming from the community. So we have a lot of barriers, we have a lot of challenges from the community. Yes. So we need to work on the more of preventive than curative. So I would love a situation where we involve the community.
Thank you, Josephine.
Yes.
Yeah.
So we need to form up some groups, and there should be a linkage between the facility and the community, and this should be strengthened so that there is proper communication between the facility and the community.
Thank you, Josephine. I think that's very powerful, actually. Betty, from your perspective, what do we need to work on? What's going to make a difference in the next 5 years or so?
Thank you very much. I just want to add that it's also emphasize what Josephine has said. The reason why community and the women must be empowered to be able to recognize, pre-eclampsia when it starts, with all those cardinal signs and some of these things that happen to them, is because there's this big myth or traditional belief that pre-eclampsia and eclampsia, especially when the fit setting, is like somebody is possessed. It's like a spiritual condition, not necessarily a physical condition. So therefore, they will resort to going to churches or the mosque or herbalists. So if they are strengthened and the woman herself is strengthened to make the decision herself to seek care early, that will be fine. My other point is pre-service institutions, pre-service. So for example, the military schools, the nursing schools, the medical schools, the notion of pre-eclampsia has to be there strengthened so that before they qualify and they are sent into service area, they already have very strong concept of pre-eclampsia and how to manage. And especially with the use of the cradle device, it is still new in our country. It's like a new concept. So for example, all schools, pre-service institutions should have cradle device. They should know about it before they qualify. And the community women, the pregnant women, if it's possible, they can have their cradle device themselves at home to monitor. It's not simple, it's very simple to use cradle if you are taught.
Yeah. Thank you, Betty. Well, I mean, what a powerful half hour to really, sort of talk about where we are and the successes that we've had, but also to, where I hope we're going. I'm going to hand back, as it's time's up for now, to Andy and Marcus to take us on to the next bit.
Thank you.
Great, thank you, everybody.
Thank you.
I think the collective experience of these panelists is just quite phenomenal. And that's something that I think APEC is going to be able to kind of really use for the future to try and share that experience, because I think this is how we're going to make a difference. So thank you ever so much, everybody. And thank you, Lucy, for taking us through that. The next two speakers are just little sound bites around research, but research that's very relevant to delivering care in challenging settings around the world. So I'm going to introduce next Tanya Robbins, who's one of our PhD fellows who's been doing some interesting work on looking at the barriers to uptake of care around pre-eclampsia. I'm just going to spend 10 minutes sharing some of the more practical issues around that research. So Tanya, if you can come on, that will be brilliant. Thank you. Are you alone? Can you take your mask off? Are you allowed to? We won't tell anyone, honest. You're on mute at the moment.
Hello, everyone. I'm just going to try and share my screen, Andy. Can you see that okay? Mm-hmm. Yeah, okay, great. So thank you so much to APEC-I for the invitation to come and to speak to you today. As Andy said, I'm one of the research fellows working with him, and I've been working on a couple of different projects in Haiti, Zimbabwe and Ethiopia. I think many of the participants on this webinar probably are much more expert in the barriers to pre-eclampsia care in low resource settings, because this is your everyday, I imagine. But I'm going to talk to you about some of the work I've been doing briefly. And sorry, I joined the meeting a little bit late, so I'm sorry if I repeat something that somebody else has said. So I don't think I need to go through this with this audience, but we know that the burden of hypertensive disorders of pregnancy is mainly in low and middle income countries, and is responsible for an estimated 70,000 maternal deaths per year and 500,000 perinatal deaths. And just thinking about this kind of looking at these maps and comparing where the burden of disease for pre-eclampsia and hypertensive disorders is highest is also where I've used the example of family planning here, but just to make the point that we know that access to services and quality of care is lacking in the places where the burden of hypertensive disorders is highest. And we also know that being able to access good quality care does make a difference. So the vast majority of deaths from pre-eclampsia are preventable. And in the UK now, the chance of a woman dying from pre-eclampsia is less than 1 in a million. And our report into maternal deaths that happens regularly, we have a really good surveillance mechanism in the UK, has shown us that actually the deaths from pre-eclampsia have massively declined over the last sort of 50 years. But it's also highlighted the fact that women who are affected by or are do die in pregnancy often have a constellation of different problems. And I think this is just important because it kind of maps onto the issues more globally. So we see that women who are Black are 4 times more likely than white women to die during pregnancy or the postnatal period. Asian women are twice as likely. Women from mixed racial backgrounds are 3 times as likely. And often women that die have various different problems, which may be language barriers, maybe social problems, which might link into delayed access to antenatal care services. And I think this just sort of, maps onto a lot of the problems that we see in low and middle income countries. And I think we've all been talking about all of these things anyway, but just to kind of reiterate the importance of the contexts of care that we're working in. And we know that maternal health and perinatal health is linked to the social determinants of health. So not just whether people get to hospital and have their pre-eclampsia treated according to a protocol, although that's obviously a very important part of the puzzle, but it's also the things that we've already been talking about on this meeting. So understanding the social and cultural contexts that women live in, and how these influence particularly pre-eclampsia. And I think Betty kind of highlighted this in the comment that she made. And one of the projects that I've been working on is the HAPPY project, which stands for Humanities and Arts in Preventing Pre-eclampsia Complications Through Community Engagement and Education. And our kind of strapline was engage, empower and educate. And we were doing some community level work with people in Haiti and Zimbabwe. We did some qualitative interviews and focus groups, so trying to find out what people understood about preeclampsia or the symptoms that might indicate preeclampsia, how people seek care for problems during pregnancy. And we spoke to a real range of people, including pregnant and postnatal women, their partners, but also other important decision makers, such as their mothers and fathers-in-law or their parents, religious and community leaders, faith healers, traditional healers, TBAs, as well as healthcare professionals. And trying to kind of understand the different barriers in different contexts and how similar or different they are across countries. So I did some similar work in Ethiopia as well. I think Andy's going to come on to speak to you about the APEC-I website and some of the resources that we've created through the Happy Project. So 2 films, we made a film in Haiti and one in Zimbabwe, are available on the website. So I'm not sure if he's going to speak to you about that a little bit later. But I guess I just wanted to really make the point that, which I think all of us have been saying, and that was a really good panel discussion where you sort of alluded to all of this, is that, of course, increasing community level knowledge and awareness is a really key part of it. But I think it is just a part of the puzzle and a part of the pathway that we need to improve and address in different contexts. And part of my work has been around trying to understand the kind of cultural nuances and think about more holistic approaches to education. So rather than just trying to dispel kind of myths as we might perceive them, as people thinking in a kind of biomedical way, trying to engage different important key people, such as those that I've talked about earlier, so religious leaders and traditional healers and elders and community leaders, rather than trying to tell people that their kind of long-held beliefs and often deeply ingrained cultural practices are wrong, thinking about more holistic ways that we can try and address some of these issues. And that's kind of what we've been trying to do through making the films that we've made in Haiti and Zimbabwe. I was just going to show you a couple of quotes. So this one from a woman in Haiti who was pregnant, who's sort of describing what Betty talked about, I think, a little bit. So she says, in the country we live in, you might have a headache and it's not a simple headache and doctors might not be able to help you. I think in that case, prayers might be a big help, because although a doctor is really good, there's nothing that the Lord cannot do. You just need to have faith. So it's kind of just highlighting this idea that often people, I found in the interviews that we conducted, that there was this kind of distinction between normal problems or symptoms, for example, a normal headache, which people might attribute to having high blood pressure or another problem, and sort of other types of headaches, which they often attributed to spiritual or religious causes, and how we try to kind of understand these issues a bit more, and how we can engage people without sort of distancing them by just telling them that what they believe is wrong. And then another quote here from a traditional healer who's talking about, I just wanted to really highlight the sort of point about the way people that seek care, and I'm sure, again, you are all aware of this and probably come across this on a daily basis. But I think this quote, so the healer's saying, talking about using herbs for teas to treat high blood pressure, and if that doesn't work, he or she will then tell the woman to go to hospital. So they'll be using papaya leaves. And I think it's just kind of making the point that often hospitals or the healthcare facility might not be the first point of call for people, and how, again, just thinking about how we try to flip that round and make a healthcare facility the first place that people go, and, you know, potentially being more holistic in enabling other people to come into those settings so that people don't feel they're having to make a choice. As part of the Happy Project, we had some partnership building meetings, and I just wanted to share these key messages that came out from our kind of discussions, which were, involving lots of different key stakeholders that we wanted to kind of include in some of the resources that we've been making. So one of them was just that all pregnant women are at risk, and we wanted to sort of stress that point, that it's not just women who, people might not have an obvious risk factor, but we need to be screening everybody for preeclampsia, and also the fact that it's caused by being pregnant and not by what pregnant women do, because another thing we found in some of the qualitative work, that there was this idea of sort of the culpability of pregnant women, and it was, I'm sure many of you know about the commonly held, the common kind of understanding about what causes preeclampsia, which is often dietary or spiritual, as we've already talked about causes, but trying to make this point that it's caused by the pregnancy and not what people are eating or doing or not doing. And this really important point that it can be asymptomatic, and trying to drive home the importance of routine antenatal care and screening with monitoring blood pressure.
Sorry, we seem to have lost Tanya briefly, but anyway, we will perhaps. Sorry if you can hear us, Tanya, because that was really interesting. But I trust you're getting close to the end, so unless you come back soon, let's just move on to our next speaker. So Alice, on a similar note, I noticed that some people on the chat have made some references to the language issues around preeclampsia. So actually, Alice, who's currently in Zambia with our teams out there, has been looking at some of the linguistic and issues around sort of research literature, and is happy to share with us some of her experience around those sort of what we've called lost in translation programs. So Alice, if you're able to come on and share your experience with us, that would be great.
Yeah, I don't think I can, my video has been stopped, but as long as I can share my screen. Here we go. I'll just share my screen. All right, hopefully everyone can see that. So thank you, Andy, and thanks to APEC-I for the invitation. And yeah, thank you to all of our panelists. I thought that was a really, really important and interesting discussion. And hopefully some of the things that I'm gonna say will build on what we've been discussing and lead on from Tanya's discussion as well. So just to introduce myself, my name is Alice. I am a trainee obstetrician from the UK, but have been working on the Cradle 4 trial in Zambia and India for the past couple of years. So I've learned huge amounts from the teams, so from Dr. Bellad, Professor Valika, Sister Josephine, who's here. So what I wanted to do was just to briefly introduce the Cradle 4 trial and the overall kind of body of work that we're doing, and then, as Andy mentioned, go on to talk about some of the linguistic challenges. And I think that everything that we've discussed so far leads really nicely onto this, because I think the real focus and the key messages that we've been hearing this afternoon have all been focused on how do we educate, how do we empower, how do we build awareness, and really, really importantly, how do we engage local communities in that process. And I think part of that is thinking really carefully about how we communicate, and particularly how we communicate and how we translate terms when we're doing a lot of this much needed research, making sure that we're doing it, as Marcus said, with the patients and women at the forefront of our minds, and really making sure that the work we're producing, the materials that we're using are truly serving them and their needs. So the Cradle 4 trial is looking at when the best time to deliver women with preeclampsia is in a low and middle income setting. And as I mentioned, it's taking place in India and Zambia, which you can see on the map here with their respective maternal mortality ratios. And just to give a very brief overview, it's looking at so women who have preeclampsia without severe features needing immediate delivery between 34 and 37 weeks, and looking at whether planned delivery at this time can reduce adverse pregnancy outcomes compared to usual care, which at the moment is expectant management and close monitoring until either the woman reaches 37 weeks, which is the point at which the WHO advise offering delivery to everybody, regardless of the severity of the condition, or until a serious complication develops before then, needing earlier delivery. So we've been open to recruitment since December 2019, and we're nearly we've nearly enrolled about 300 women, and women who agree to take part are randomly allocated to planned delivery within 48 hours of randomization or to usual care. And this is just an example of one of our trial posters designed by the team here in Lusaka, that is up and about in many of the local healthcare facilities here in Zambia. And the reason why I'm putting this up as an example is, again, just to try and illustrate some of the key concepts, some of the key danger signs around preeclampsia, because when you're asking women who've been diagnosed with preeclampsia, it's a very stressful time for them, and there's a lot of information to take in. And again, thinking about some of the information that's on this poster and how that's going to be received by women, how you communicate what the condition is, what the implications of that condition might be, what the impact could be for them and for their baby, and then beyond that, also trying to communicate the purpose of the research and what taking part in the research might involve. So these are all really, really important things to try and communicate as clearly as possible. And speaking about research and sort of terminology and conducting research in different contexts, I wanted to quickly share a video, just a few minutes, just highlighting some of the key findings from the first phase of our Cradle 4 study, which again was trying to look at how best we can understand the context in which we're delivering research, and as we've heard, from the panel discussion today, we've got so many different people from different parts of the world sharing their expertise and that we can learn from. And I just wanted to highlight some of the key findings from Zambia, about what we learned about the trial environment. And I'm just going to hope that I can share my sound. So please let me know whether you can hear this.
Preeclampsia is a pregnancy complication affecting up to 12% of pregnancies in many countries within Africa. Globally, it is responsible for 76,000 maternal deaths and 500,000 baby deaths every year. 98% of these occur in low and middle income countries. Evidence from a UK setting has shown that planned early delivery in women with preeclampsia without severe features between 34 and 37 weeks reduces adverse maternal outcomes without significantly increasing neonatal morbidity. However, this intervention is yet to be evaluated in a low or middle income setting where the majority of disease burden lies. Prior to designing a randomized controlled trial to evaluate this intervention in India and Zambia, we carried out a 6-month feasibility study to better understand the trial environment and guide development of our intervention. This involved conducting a case notes review, carrying out 29 interviews with a cross-section of healthcare providers, and facilitating 8 focus group discussions with pregnant women and their partners. Combining evidence from these 3 methods, we examined the potential barriers and facilitators to planned early delivery, assessing 3 key domains: disease burden, current management, and acceptability. We evaluated each of these from a maternal perspective, an infant perspective, and a health systems perspective. I'll highlight some of our key findings, starting with the powerful lived experience of both women and healthcare providers, which acted as a strong facilitator. However, there were also many myths and misconceptions regarding the underlying causes of preeclampsia. Reassuringly, the paediatricians we spoke to reported good outcomes amongst late preterm infants, despite very limited resources. Overall, participants recognised the potential of early intervention to save the life of both mum and baby. And we also found that on the whole, a large amount of trust was placed in doctors as decision makers. Nevertheless, there were concerns about the cost of neonatal care, particularly in India, and a reluctance amongst some women to undergo induction of labour. Quantitative data supported these findings, showing that 1 in 5 women with preeclampsia experienced an adverse outcome beyond 34 weeks of pregnancy, but also confirming that in infants born after 34 weeks, their birth weight was above the threshold for neonatal unit admission. Importantly, we found that the proportion of antenatal and postnatal baby deaths was very similar, suggesting that it may be at least as risky to continue the pregnancy as to deliver early. Finally, from a health systems perspective, we identified a number of discrepancies in resources available between the 2 countries, with the example of creatinine testing shown here. In conclusion, as a result of this study, we were able to confirm the need for our intervention, gain a unique insight into the management of preeclampsia, and better understand the local environment to adapt our protocol accordingly. Thank you for listening.
So that was just a very a brief overview of some of our key findings, as I said, from the first phase of Cradle 4. And I think it really, again, demonstrates what we've heard already about understanding community perceptions of preeclampsia and trying to mitigate some of the gaps in understanding, both amongst healthcare professionals, but also women and their partners, and working with communities. And I think that this is particularly important when we're thinking about preeclampsia research and the way that we conduct that, and really, really important to bring these communities in. And what this
preeclampsia is a
I'll try and So what this then leads on to is the Lost in Translation study, which is a project that we're doing alongside Cradle 4 and was born out of some of our experiences with the first phase of this study, looking at the difficulty in translating some of the key concepts and terms used around preeclampsia. And I saw that Isabella perfectly introduced the study in the chat by mentioning that in many local languages there is no equivalent word for preeclampsia, and we've absolutely found that when we were trying to design our participant information leaflets and our consent forms as part of the first phase for Cradle 4, and not just preeclampsia, but lots of other words that are associated either with preeclampsia or with other pregnancy-related conditions. So proteinuria, for example, contractions, ultrasound, lots of the medical terminology and lots of the legal terminology that is often used in these documents is very difficult to translate. And I think that that's an important problem that we talk about and think about, because if we can't translate these terms both linguistically and conceptually, then we're going to struggle to engage the communities that we most want to reach out to and work alongside. So again, this is just a few slides to highlight what we're trying to do at the moment in Zambia with Lost in Translation, and also really reach out to all of you and hopefully, you know, the wider sort of APEC International community, both to perhaps prompt you to think about whether this is an issue in the places where you're working or the research that you're conducting, and also to hopefully generate some collaboration. And I think that would be a really great outcome of APEC is to collaborate as a group and to try and think about the terms that we're using and how we can improve them on a global level. So just to briefly recap again, I know everybody is very familiar with this, but when we think about informed consent, and I'm talking about this in the context of people taking part in a randomized controlled clinical trial, but I think it's equally valid when we think about consenting a woman for an emergency cesarean section because of severe pre-eclampsia, for example. So the person providing consent, giving consent, obviously needs to have the capacity to do so. They need to be doing voluntarily, and they need to be provided with sufficient comprehensible information. And it's the comprehensible aspect of this information that we're trying to drill down and focus on in this study. And some of the issues that have been described previously is that a lot of the recruitment materials that are used in research as a whole, but certainly pre-eclampsia research and maternal health research, are developed and written in high income settings, and they're often designed to protect the funder or the sponsor of the research. And as a result, they use very complex medico-legal language, which is difficult to understand in the first place. And then this is further compounded by the fact that in many of the settings where this research is being conducted, there are low levels of literacy and education, which makes it even harder to understand. So this is a really important paper, which again highlights, they looked back at comprehension of trial participants in various different African research settings and found that 80% of trial participants in this study did not understand the key domains of informed consent. And some of the key areas that they picked up on was the concept of therapeutic misconception. So the idea that if you're taking part in a research study, that you might receive better healthcare. Whereas obviously the whole point around research is that we often don't know which management strategy is better. A lack of awareness around voluntariness and the right of withdrawal, so people thinking that they have to take part or not feeling like they could withdraw. And then randomization and placebo, which are again very difficult concepts and terms to translate in English, let alone trying to then translate them into other local languages where the equivalent terms may not exist. It may not be part of the general lexicon of that particular population or community. How does this relate to pre-eclampsia? Again, we don't need to recap these statistics, but I think just the point being that pre-eclampsia is one of the leading causes of maternal mortality in the world, as we all know, that the vast majority of these deaths, again, as we've heard, are happening in low and middle income countries, and in particular in sub-Saharan Africa and in South Asia. And so when we're thinking about where we need to be targeting pre-eclampsia research, awareness building, education, then it's in these places, and these are often involving very vulnerable women in very vulnerable healthcare systems. So I think it's even more important that we go above and beyond to think about how we communicate and how we build understanding. And part of building understanding, part of improving awareness, rests on communicating, and communicating in a way that people understand, speaking to them in their everyday language that they're used to using. And I just wanted to highlight the points here by showing you some examples. So here we have one of our Cradle 4 participant information sheets, which was designed according to King's College London template, and I'm sure many of these templates will be familiar to you. There's another example here, just to show that it's not just King's, from the WHO about the things that they recommend should appear on an informed consent document. And again, this is an invitation to all of you to, and I would love to keep on talking about this after today, because I know that we don't have a lot of time. But, so for example, those of you in APEC Ghana, thinking about these terms here and how you would translate them into local languages in a way that can actually be understood by the women that are experiencing pre-eclampsia and who are attending for care. And I know certainly when we've been through these forms in Zambia and worked with our translators who are language teachers, trying to translate words like pre-eclampsia into Nyanja or Bemba, which are two of the most common languages here, is very, very challenging. Again, even simple terms like study and what that means when you try and translate it literally, the meaning can end up being really, really distorted. Risk is another word that, again, can have very different meanings depending on which words you use in Nyanja or Bemba. I'm sure our panelists, again, will have more experience on this than me, but I think it's a really interesting and really important problem to just go through and think about some of these terms and some of the barriers that might be encountered when trying to translate them. And that's certainly been our experience. So again, in Cradle 4, we found issues with lack of direct translation, also a lack of familiarity with written versions of the local language itself. So whilst people will be fluent speaking in Nyanja or Bemba, they may not be confident in reading it. So you could produce a beautiful translation that's been literally translated by local language experts, and it could still be just as meaningless because it's not actually written in a way that people can understand or that can read. And this is again an example of one of the things that we found in our back translations. So we were trying to explain that there would be no direct financial compensation by taking part in the study, but that it might help similar women in the future. And this was the translation that was done, not because anybody was was deliberately making any mistakes, but just the challenges in trying to directly translate something that's written in very complex medical legal language in another country. And you can see that the meaning's been completely distorted. So what we're trying to do is to think about what are the most frequently used terms in maternal health recruitment materials, like participant information leaflets and consent forms, but also I think, relevant to APEC-I, the information and the educational materials that we would want to be disseminating and giving out to people. And how might these terms be translated into local Zambian languages here, but also, again, as I've said, where you are all working as well, and what barriers might be encountered when doing so. And then what's the best way to overcome these barriers? And can we actually generate some context-specific terms that would offer potential research participants and women who have preeclampsia, who you are treating at your healthcare facilities, a truly robust, informed consent process that actually meets their needs? So far we've held some workshops here in Lusaka, and again, just some examples here of some of the keywords that came up as being really challenging to try and translate. And we're in the middle at the moment of conducting some in-depth interviews with key informants here in Zambia. And then following on from that, as I've said, we hope to develop some key terms and some phrases relating to maternal health in local languages that, again, we would love to then be able to share and to share on the APEC website, and for that to really be a forum for collaboration and for everybody that is working on these issues in different parts of the world to perhaps replicate a similar process and actually build up, an international glossary of terms that can be utilized by all of us. And finally, to conduct some community focus group discussions to explore how these terms are understood and actually make sure that they are fit for purpose and that they're meaningful, again, to the women that we are working with. So that's everything. It's quite it's a bit of a grand aim, but I know that we've got a really big community at this meeting today, and between all of us, it would be fantastic if we could get there. So I will stop talking now, but thank you very much for your attention and for the opportunity to speak to you all today. And thank you.
Thank you, Alice. I'll start my video if I can. I think somebody's stopping it, but anyway, I will just introduce the next speaker. So it's absolute delight to be able to invite Professor Shiva Gouda, who's now becoming a long-term collaborator, an excellent colleague and a friend, who we've now worked with for some time very successfully. He's Professor of Physiology, so he's a clever doctor. He's also Director of Research at his university, and is based in Karnataka in India. And we are all thinking of you in India at the moment in these very challenging times. Remarkably, they are continue to beaver away and deliver their work, which is phenomenal. We know how challenging it is, so congratulations on that. But Shiva, you've kindly agreed to share some of your research with us. We've given you a slightly broad brush title about aspirin, the panacea for the world, as it were, because aspirin is one of those very exciting, cheap interventions which potentially could be rolled out everywhere, but we'd like to know your take on what you've discovered. So thank you very much for taking the time.
Thank you, Andy, and pleasure to be part of this interesting session. Let me just share my slides. Yeah, I hope everybody can see my slides. So good afternoon, good evening to friends, wherever you are. The outset, I bring greetings to you all from my university in Belgaum in South India, in Karnataka. When Andy, a longtime friend, collaborator, and a great researcher, sounded me on this particular international meeting and said, can you share some of your work? I thought, let me talk about the aspirin trial that we were involved on behalf of the NICHD Global Network for Women's and Children's Health Research. And then as I started putting together the presentation, I thought, even though aspirin sort of will remain the sort of the central focus of the presentation, I also thought that I might as well share some of the other research that is revolving around aspirin and the whole pathophysiology of preterm birth and pre-eclampsia, hypertensive disorder. So I won't be speaking aspirin alone, but some of the recent research that our group has been involved in, both as part of the NICHD Global Network as well as the WHO Collaborating Center working in the area of maternal and perinatal health research. I'm sure most of you know these numbers, and I won't get into each one of the numbers. The global burden of preterm birth. So on an average, across the vast multitude of countries, it averages around 13%. And this is not unique to low and middle income countries. You see, even high income countries also have a similar burden. So, the intervention that we are talking about in terms of reducing the burden of preterm birth are not necessarily targeted at low and middle income countries, but in settings where there's a burden of preterm birth, and that sort of cuts across the continents. And if you look at the map, the darker the shade of blue, the greater the burden of the preterm birth. Now this is 2012 report, and what I would like to present is data from the NICHD Global Network for Women's and Children's Health Research. We have sites in South Asia, Africa, and Guatemala and Central America. So it sort of cuts across the globe, and although mostly focused in low and middle income countries, but these are the areas where the burden of preterm birth and mortality from preterm birth is probably among the highest. So as part of the network, we are running a maternal newborn health registry that started in 2008 May. So as of this month, we've completed 13 years of the registry, and it's a prospective registry of pregnant women residing in our geographical clusters. And we track the pregnancies through delivery and 42 days postpartum. And over the years, the registry has got refined to almost achieve 100% enrollment before 12 weeks of gestation. So we are even able to capture some of the early pregnancy losses. So as of this month, we have close to 800,000 pregnancies in our database, and Belgaum and Nagpur, the other Indian site, together contribute almost 28–30% of the registry database. And what we monitor are maternal and neonatal mortality, stillbirths, maternal near miss, and some measures of healthcare to tell us as to what's happening in these communities over a period of time. So as I said, there's a fair bit of representation from all of the regions that are part of the network. Of course, Bangladesh is a recent addition to the network, so their numbers are small. But the point is that South Asia, between India and Pakistan, have the major burden, and that is where, of course, the population density is also the highest in terms of the global population or the demography. The other thing that I want to point out here is that our registry database is nearly complete in terms of our ability to track the delivery outcomes of all pregnant women residing in the geographical area, as well as the 6-week outcome of the registry population. And these are the mortality numbers. And what I would like to again point out is, we still are dealing with fairly high rates of stillbirth, early neonatal deaths, and neonatal mortality, as well as maternal mortality, which is still in the 3-figure mark. I'm sorry about that. So we have a fairly large burden of both maternal death and early neonatal deaths, as well as stillbirth. So between the early neonatal mortality and stillbirths, we have close to 45 to 50 perinatal deaths per 1,000 births. And looking at the issue of interest for us, the preterm birth rate, our own data says that it's around 15%, and of course the highest burden being in Pakistan, around almost close to 30%. So it is in that context that we are currently just about finishing up a study trying to understand the burden of preterm birth, the causation, as well as of stillbirths. So the study led by Dr. Goldenberg and Beth McClure from RTI with our collaborator from AKU in Karachi. And what we are looking for is to assess the cause of death among stillbirths and preterm births in low resource settings. We enrolled 5,000 preterm pregnant women, and we have assessed 1,400 perinatal deaths as part of the study, 700 preterm neonatal deaths and 700 term and preterm stillbirths, and as well as 200 term controls. The study site in India is in central Karnataka, further down from Belgaum, and Karachi in Pakistan. I'll share some of the findings from the stillbirth component of the study. The neonatal component is, we are just about wrapping it up. Hopefully we should be through with that in another 2 or 3 months. And what sort of comes out as an interesting finding, and the paper is almost on the verge of getting published in BJOG, so you'll have a chance to look at it in more detail very soon. So we looked at 4,000 placentas of stillbirths, preterm live births, and term live births, and an expert team of pathologists at both the sites using the Amsterdam criteria examined the histology. And basically the framework comprises of looking at maternal vascular malperfusion, fetal vascular malperfusion, and inflammation in terms of chorioamnionitis and phenicitis. And what we find is that among stillbirths, the prevalence of maternal vascular perfusion is 58% compared to either preterm live births or term controls. Similarly, if we look at the fetal vascular malperfusion, it's almost 20% among stillbirths. Chorioamnionitis, 30% of all stillbirths have chorioamnionitis, and 10% of the stillbirths have phenicitis or inflammation of the cord. So indicating that the maternal vascular malperfusion is sort of the major finding in the placenta of stillbirths. And if we look at the causes of or the conditions that are associated with these stillbirths, 71% of hypertensive diseases of pregnancy that end in stillbirth have maternal vascular malperfusion. So I think that's sort of the key finding here, and this is the reason why I wanted to share this, these findings in today's session. So to sort of summarize, the placental histopathology shows that the information from that is probably much more important than even data coming out of autopsies. And the most common finding among stillbirths in placentas is maternal vascular malperfusion, and it's probably closely associated with many other clinical conditions associated with stillbirth, including pre-eclampsia, fetal growth restriction, APH, and fetal asphyxia. So if we are able to identify maternal vascular perfusion using either growth factors or even an ultrasound, we probably have the best chance to identify pregnancies that are at risk of stillbirth, and then maybe develop interventions to prevent the occurrence of stillbirths. So if we extrapolate those findings and try to understand the cause of stillbirth, so what we did is use an expert panel that looked at clinical data, placental evaluation, and we also did what's termed as minimally invasive tissue sampling, which is a sort of an alternative approach to full clinical autopsy, where you just put needle in the key organs of stillborn babies and try to sample the tissue and then analyze it, even including PCR. So to date, 545 stillbirths have been evaluated by the panel, and they look at maternal cause, placental cause, and fetal cause. So what comes out of that analysis is a placental malperfusion, intrauterine hypoxia, and eclampsia, pre-eclampsia as the three leading contributing causes for stillbirths. So therefore, maternal, placental, and fetal causes of death, I mean, if we analyze that, either hypertensive disorders of pregnancy or placental maternal vascular malperfusion or intrauterine hypoxia emerge as the three most important causes for stillbirths. So prolonged labor, post dates, prolapsed umbilical cord, these are all known to cause fetal hypoxia and fetal death. Infection, either maternal, placental, or fetal, are also associated with stillbirths, but much less than the whole triad of preeclampsia, placental malperfusion, and fetal hypoxia. So if we look at, and again, I won't get into all of the details of the pathway to preterm birth. What again sort of stands out is the inflammatory pathway affecting the placental function, leading to preterm delivery. So it is in that context that we started looking at aspirin as a potential intervention to address the whole issue of preterm birth. Of course, aspirin is not new. It dates back to 1500 BC. Hippocrates used it. Felix Hoffmann, of course, formulated acetyl salicylic acid for the Merck Corporation. Bufils in 1985 performed the first RCT on 102 women at risk of preeclampsia or SGA using a low-dose aspirin of 150 milligram versus placebo, and showed that there is a benefit in reduction of preeclampsia. And a 2019 Cochrane meta-analysis using 77 trials with a total N of 40,000 odd. Of course, 9 of them being large trials with more than 1,000 women enrolled in them. So that's the sort of the evidence that supported the NICHD Global Network trial that we published last year. So here what we did is, we targeted the intervention against only nulliparas with the rationale that, here the risk of preterm birth is unknown. And in a recurrent preterm birth, you probably know the cause and therefore you can treat it. But in a nulliparous woman, you really don't know who is at risk of developing or ending up with a preterm birth. So we thought, and based on again earlier published literature, which indicates that the earlier you start the aspirin supplementation, greater the benefit in terms of reduction of preterm birth, preeclampsia, hypertensive disorders of pregnancy. So what we targeted was to initiate the supplementation before the end of 13 weeks, and then continue the supplementation through 36 weeks and see whether we can reduce the incidence of preterm birth. So the RCT enrolled almost 12,000 women. Our own site in Belgaum, we enrolled 2,800 women out of the 12,000. So it was a randomized placebo-controlled trial. We used 81 milligram, the baby aspirin. Of course, people question as to why 81, why not 75? This is the whole issue is, using 1 1/4 grain of the full dose of aspirin of 325 milligrams. So whereas most countries use 75 milligrams. Basically, there's really not much of a difference between the two doses in terms of their efficacy. It's just the pharmacological preparations in the different countries and the way, the metric that they use for the measurement. Of course, the primary outcome was reduction in preterm birth by 20%, and the trial occurred over 27-month period. So the major outcomes, and again, the details are there in the published paper that came out last January in the Lancet. There was a reduction of overall 11% preterm birth, that is less than 37. But more interestingly, the greater impact was on the early preterm, that is less than 34 weeks, much more larger effect, and a 14% perinatal mortality. And in the context of, this setting where the trial was conducted in South Asia, in Africa, a 14% reduction in perinatal mortality translates into a huge number in terms of actual lives saved. And the good thing is there was no difference in terms of the adverse events or birth defects in the population that received aspirin. So we did publish that just this January in AJOG Global Reports, that there are no safety signals with the use of baby aspirin during pregnancy. And we just got funded from Thrasher to look at the longer term safety in terms of neurodevelopmental outcomes at 24 months. So that follow-up study should be starting fairly soon in the network sites. So to sort of summarize the whole evidence in terms of low-dose aspirin, both the meta-analysis as well as the aspirin trial indicate that there is a reduction or benefit in terms of reducing perinatal mortality, preterm birth, and preterm HTP. Of course, CLASP and ASPRE, the two other major trials, also support the benefit in terms of reduction in preterm birth and preterm HTP. There is some debate in terms of maybe a higher dose of 100 or 150 milligram probably may have a better effect in terms of reduction of pre-eclampsia and preterm birth. But as of date, no dose escalation trials have been performed. The timing, I think, is probably the most important. Only those studies where the aspirin was initiated less than 16 weeks have really shown any benefit in terms of these three outcomes. And of course, maternal and neonatal safety are well established. There was a comment earlier in terms of biomarkers. So as part of the aspirin trial, we did a small sub-study just at our site looking at the impact of the supplementation on markers of inflammation and placental function. So we looked at C-reactive protein as an indicator of maternal inflammation, and AMH and alpha-fetoprotein as an indicator of placental function. We collected samples at 2 time points, 10 and 13 weeks of gestation. The first sample, that is 2 weeks after the aspirin was initiated, and then in the second trimester, at around 17 to 21 weeks of gestation. So in 269 participants, we were able to collect both the serial samples. 45 of them delivered preterm and 224 delivered term baby. Of course, this is a mix of both aspirin and placebo groups. So we did a nested case control analysis, and what we found is that the LDA supplementation does lower the level of alpha-fetoprotein within 2 weeks of initiation. So therefore, its measurement in the first trimester may be a useful biomarker to understand the efficacy of LDA in pregnancy. So this is just accepted in maternal, fetal and neonatal medicine. So again, I don't have much time to get into all of the details, but This is coming up very shortly. So sort of what does this all mean? Now the WHO recommendations are more than 10 years old. The data has grown substantially from the last data that was used for the WHO guidance from 2007. So more than 20,000 women have been added to the data set, mostly contributed by aspirin, and EGA. I mean, the three major trials. Indication criteria is also different than other societies. There are three trials that are of interest as far as the whole use of aspirin, pre-eclampsia, and preterm birth are concerned. There's a Dutch study which is probably recruiting as of now. NICHD MFU was planning a study looking at 81 versus 162 for pre-eclampsia prevention, and then of course the impact looking at 150 versus 81. So on that note, I'll end my presentation. Again, I've tried to compress information beyond just the aspirin trial, which may be of interest especially to this audience. And once again, thank you, Andy, Alice, and the entire group for having me today.
Shiva, thank you so much. A very impressive feat to get all that information in such a short time, and I think you know, aspirin is kind of one of those quick wins, I think, and learning the best populations and what it's doing, when to give it, is going to be our challenge, I think, for us in the international community. So thank you for sharing that with us, and we'll watch this space very carefully. Keep up the excellent work in that area. So in the interest of time, I'm going to move smartly on and just finish off the meeting. Really just to thank people, but also to quickly show you what we've created so far. I say we, it's kind of us, everyone in this meeting, I hope will be part of the APEC-I family. As I said earlier, this is a blank sheet. We want to hear from you. We would like to know your ideas. We would like to know if we should be doing other things, new things, meetings, the format of those meetings. And basically, if it's going to help us, you know, people will vote with their feet, and we can learn from each other. I certainly think that this is a huge opportunity given the impact of pre-eclampsia internationally. The website so far is got a format, and I just want to take you through it very quickly, just in a few minutes. It's obviously free to access. It's apecint.org. I want to thank Kath Wilson and Jack in Cape Town, who have spent time putting this together, and particularly with Tanya. But it's a work in progress, and it's evolving. And we'd like to hear from you if you have any suggestions about it. But let me just quickly share my screen and maybe take you through this. I'm assuming you can see it. Yeah, so here is the basic website. It's very simple in that it's got a women's and families section, a professional section, and then some general information. So our intention was to make this simple and user-friendly for everybody and anybody who wants to get information about pre-eclampsia. We don't want to create a new web source, but we want to direct people to sources that already exist. And if you know of other sources of good information that we can link to, we will get the permissions to try and put it onto this website. So one of the great things APEC has done over the years is provide good information for women. And so we have a whole section on what is pre-eclampsia. Now, obviously, we want to make this tuned into local circumstance. So this is just an example whereby we have videos in the different languages. So in this case, I think in Creole, and if you play the video, basically this is in the local language. So I won't go into it, but as you can see, there are videos on what is treatment, about the baby, birth and afterwards. Ideally, we would love to create this entity for anyone who wants it in any language, but we would need your help to create the videos and send them to us. So that's one idea. There are the normal kind of questions and answers, which have been the sort of basis of APEC information, and you can click on any of these to get information leaflets. And depending on people's wishes, we can turn this into any type of resource that we want. There's films and information on here. This again is evolving. There's a couple of the videos that Tanya was telling you about. We'll actually play this video at the end. It's about 20 minutes. I'm not going to do it now, but as we leave the meeting, people who want to stay and listen to that. Now, there's a professionals resource, and there's a number of sections in this. There's education and training. So, for example, we have put all the international guidelines we can find in here. So if you click on international guidelines, up will come various kind of WHO, FIGO, ISSHP. You can click on those and read the guidelines. So you don't have to go hunting. And this is all to do with pre-eclampsia. We have a research section. We try and put recent and upgoing publications here. And we have summaries on those. And thanks to Anna for her help in getting that. And there's guidelines for healthcare workers and so on. There's a FIGO textbook here, for example, and there's a whole resource of the Global Library of Women's Medicine, which is a fantastic resource. So, for example, just to show you, if you click on here, you get to the FIGO textbook. If you click on a chapter, it will come up and it's all there for you to see. And these are all written specifically for the world, not particularly for a high resource setting. So that's all very useful. So like I said, there's a lot of information here. I would like you to go and play with this. What we really want to do is help you create a local entity that is useful. So APEC Ghana has obviously been a fantastic example of what can be achieved in country, and they've got a whole charity set up, and we would support you in terms of APEC-UK in knowledge sharing about the structures of setting up a charity. But I think all the kind of knowledge and information needs to come locally because of all the kind of cultural barriers and so on that Tanya was telling us about. We suggest a patron, a chairperson, a functional coordinator, and if we can have students who would like to adopt a country to help with some of the donkey work, that works incredibly well in terms of nurturing the next generation. To do all this, we would like you to contact us. We will send you a link to be able to do that with your ideas, and maybe, yes, we would like to help. And if we get a lot of interest from an individual country, maybe we can facilitate you talking and creating it. And we would hope on this website to have your own page, your own domain for each country with shared information between different areas. Now, I'm taking it, you can see my slide here. I just want to finish off here by just saying, here is there's an interest form that you can fill out and send to us, and we will help try and facilitate next action. We'd like to hear your ideas. What would you like next? Did you find this today interesting? Would you like a shorter forum, a bigger forum? Would you like more academic lectures and just stuff that we all want to do? I've really enjoyed today, and I think it's such an opportunity to move forward in this incredibly challenging area. Here is our website, APEC Int. I'm going to finish off by just particularly thanking the APEC team, like Marcus Green and his crew. So that's Rowan, Anna Martin for all our hard work behind the scenes. And also all you for taking the time to listen, and we really would like you to engage, so together we can kind of, what we really want to do, make a difference to the women of the world in what continues to be a devastating disease. And I believe because of the nature of pre-eclampsia, you can detect it, you can do something about it, you can turn it around relatively cost effectively. This is a quick win for all of us. And this massive discrepancy that exists around the world, we can change in our working lifetime. Let's do it. So Marcus, if you'd be kind enough to go out, put comments in the chat if you want to feedback. you know, good and bad, you know, things you'd like change, whether you think this is a waste of time, whether you think it's brilliant, we'd love to hear from you. And Marcus, if you couldn't give us the final, the Astrid's video, which is just one of Tanya's videos she was telling you about, which addresses some of the cultural issues in Haiti, please feel free to sit and watch that or access it on the website whenever you feel free. And please do the MCQ. I'd love to see what your answers are. They are challenging. The best marks were only 50 out of 70, and a lot of people got them wrong. And we will send you what we believe are the correct answers. So they are educational and a little bit challenging. All right, enjoy the rest of your day. I have to go back to the operating theatre. Take care. Marcus, you're right to get this video on.
Hello, tout le monde qui a écouté l'émission, c'est Mr. Joe, une grande salutation à toute la population. Et c'est un message positif que je voulais passer, un message de prévention. Pour toute femme enceinte, s'il vous plaît, pas porter négligence les nous enceintes, allez à l'hôpital pour nous recevoir soins médicaux ou soit prénatal. Il y a un clinique qui a pris au Cap qui demande pour toute femme enceinte de venir recevoir médicaments et puis porter une grande surveillance sur tout le monde qui va porter. Merci.
Chérie, moi j'ai senti bon.
Vous parlez travailler jeudi, hein?
Oui, moi le travail.
Vous connaissez la petite besoin là pour bébé?
Moi connais chérie, vous pas besoin que tu m'abjures ça. Oh, qui ça gagne chérie?
Tout ça m'a pensé ça que t'es passé Béatrice avec bébé là.
Mais c'est qui est-ce qui Béatrice?
Vous pas connaître dame qui met boulanger?
Ah tché, vous sentez pas bien? Ou en forme, ou pas besoin de voir aucun docteur.
Mais chérie, il était très bien. Après, il fin tomber malade en pile et puis il perd bébé. Et si toutefois ça arrive?
Pas quelqu'un qui crite comme ça pour perdre un bébé. Quand même, il y a une raison. On va il pas compte de qui cause bébé à te mourir.
Moi connais pour qui grossesse li pas ici. Li t'a vivre dans péché. On nous dit c'est pas seul bobo li t'a battre client yo.
Ah mamie, ou méchant. Est-ce que c'est tout bon vrai? Li toujours l'église, mais pas quoi ça vous dire.
C'est sous chemise bleu yo tâche.
Mais vraiment, ça paraît étrange. Peut-être si li tel un docteur, tu qu'à dire mais qui ça le gain?
Docteur a très cher. Docteur a bon médicament pour faire bébé gros dans ventre. Et puis après retourner pour faire césarienne. Opération ça a très cher. La coûté en pile l'argent. Moi pas vle pisi a petite moi tripoter. Et ou t'a vle ça tout? Moi faire 6 moun. Sans aucun docteur. Et on tout bien. Excepté si là qui ont ti Jean Malkit.
Ah mamie, ou quoi bria dit ça bon menti?
Quand il coule trop de soleil, mais il pas tromper la pluie. C'est comment c'est la sortie quand même. Bon dit on bagaille. Ou si une jeune femme qui est en santé, quand on te crée pas bon Dieu pour te faire si moun. Si son inquiété de la vie, bat pour qu'un belle dignité ou pour porter bébé ça avec fidélité. Et puis pas mon docteur ça, aucune aide. Tu n'es pas chambre de pour mettre lui.
Astrid. Oh ma fille.
Chita ensemble avec. Ça va être comme ça.
Petit problème. Moi je fais junior fashion encore oui.
Ah. Qui ça y dit ça fait faire ça?
Ah, c'est faute pam. Ma pété t'aime des bébés en pile et puis le bouquet t'aime que bébé pas gagner.
Mais c'est un bagage normal pour inquiéter, c'est ou même qui a porté l'autre monde dans pas pour qui ça son problème.
Moi petit genre route pour me dire ça c'est. Moi pas gain qui mal ensemble avec. Moi-même qui t'a réfléchi façon Béatrice petit bébé lié rapide comme ça. Et puis ça fait me réfléchir me doit au docteur.
Mais moi de chimé pas veut dire perdu pour ça. Car on a pu aider surtout même qui enceinte.
Mais non, moi pas gain pile l'argent pour nous payer transport pour aller en centre de santé. En tout cas, Junior pas connaît docteur non, ni maman li tout.
Achita après conseil nan ma femme ça non, li 3 caille. Sérieusement, est-ce qu'on pense au problème?
Non, c'est ça même. Moi sentiment forme. Moi dois prendre responsabilité comme yo maman.
En tout cas, elle est vraiment entrée dans tête li. Écoutez ça m'a dit. Il y a série de bagages moun guérison connaît, il y a série de bagages docteur connaît, il y a des bagages grand monde tant cousine connaît. Ou doit aller un docteur, surtout même qui est enceinte pour la première fois.
Ou vraiment pensez on t'a dû aller? Junior capable aimer ça.
Juste aller puis en suivre, s'il vous plaît. Si pas gain, ça va pas chaud mal réfléchi. Gen bagay k'ap passer en dedans ou pas ka connaître. C'est le docteur qui a détecté. C'est ça même y a cherché, une maladie invisible.
Ma fille, comment faire connaître toute bagay ça ou pas même gen aucun petit monde?
Ça, m'a fait confiance.
Allah au grand Seigneur. Alors c'est bon, moi j'aime au Seigneur. Moi j'aime au Seigneur. M'adorer au Seigneur. Allah au grand Seigneur. Béni soit l'Éternel.
Sauvez au nom de Jésus.
Astrid! 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 Astrid, comment ça tout?
Li besoin pas encore à cogner.
Li besoin un docteur.
Li pas besoin docteur. Li te gen mauvais esprit, tremblement et puis qui m't'a sorti dans bouche li. Li qui fait un bagay qui cause ça arriver. Moi connais qu'elle a caché mon bagay.
Comment qu'a fait son bagay comme ça? Comment qu'a fait dire cacher un bagay? De l'autre côté elle tête sur li besoin un docteur. On a tout ça pas d'arriver on t'a jeune comment biote aider.
Pas une peut-être li avec cause docteur. Ou pas même connaître qui ça va dire. Moi faire 6 moun et ou même une autre ka kembe vivant. Mais il est bon corps.
Astrid, comment ça tout? Moi vraiment voulu me lancer ensemble de ça.
Qu'est-ce que ça te discussion ça? Pour qui m'a mis tout ça?
Moi vraiment voulu me lancer ensemble de ça.
Ma fille, pour qui? Qui bébé? Qui sauve les dîmes?
Moi pas de gentil ça avant. Moi t'ai gagné un bébé. Et une petite fille. Moi j'étais enceinte déjà. Un jour soir, moi j'étais là quand moi et puis moi senti un vent passer sur moi. J'étais gagné un mauvais tête fait mal et puis moi pas de carré clair. Tout ça moi t'ai regardé tes flou. Moi pas connais ça qui t'est passé. Moi songe moi t'ai levé dans nuit moi seul. Moi t'ai gagné un besoin d'aide. Moi t'ai obligé à louer un mambo. Il t'a dit pour moi aller à l'hôpital, mais moi pas aller parce que moi t'ai peur docteur. Il retiré la tout moi et puis les brûler. Nous faisons mauvais esprit au aller, mais moi j'étais toujours malade. Quelques jours après, moi j'étais une douleur en bas de ventre. Après, je vais la prendre encore. Moi, j'ai un ami qui t'a travaillé dans le centre de santé. C'est lui-même qui était jeune. Moi. Il dit que c'est grossesse là qui cause qu'on a une crise. C'est pas ni une expédition,
ni un mauvais esprit. C'était une maladie normale qui cause moi te perdre petit moi. Maladie ça pas gain aucun symptôme parfois. C'est seulement le docteur qui a détecté et puis guéri avant crise là bon. Moi te ka sauver petit moi si moi te aller un docteur puis bonheur. Malheureusement, moi pas de faire ça.
Je suis vraiment désolée de ce que ça t'est arrivé. Je n'ai pas aucune idée.
Astrid, maladie ça que moi te gain. Maladie ça que ou gain. Il ka tué. Il ka tué petit.
Moi, perds ma vie.
Ou pas faire rien qui mal. Ou juste besoin d'un docteur seulement pour jeune traitement.
Alors, le junior pour moi. Dis que mon besoin d'une machine.
Ma fille, m'occuper qu'on y a là.
On te voit ça là, je parle de ma fois qu'on a dit vraiment occupé.
Ou pas qu'à dire ça me fait.
Fréquent. Pour nous faire ce soir, faire bonne pression devant un mot, hein? Et bien, mais à ce sorte font crise. Oui, qu'on est toujours frappé, mais parfois toujours envie de jouer devant un mot. Et bien, nous avons besoin de voiture pour nous mettre dans le centre de santé.
Moi, je dépense tout comme moi.
Qui ça?
Bon, qui s'entend de la junior? Bon, déjà qu'on devrait faire Timoun, il faut toujours mettre un bail serré pour lui. À marcher, on fait 0 winner. Bon, mon moto de moi, ma carrière d'accès, ma bonne roule. On a.
Chérie, comment ils font?
Je me sens plus bien. Mais il était mauvais. Moi, j'étais tombé. Je suis dans le docteur plus bonnet.
Je suis vraiment désolé de ce que vous pas de côté.
On nous déplace avant mon moment là.
On va nous faire chercher nous. Quand on va parler à Astrid, on va écouter madame ça. Reste là, fait dans ta famille.
Non, maman.
Qui sont dit là?
Pas entre bouche dans barré comme ça. Nous parlons quand docteur. C'est ça, livré.
Comment fait qu'on essaie ça livré? Gardez nous les malades. Oui, et puis tout les besoins un docteur. Comment on va faire qu'on nous va même your maman? C'est arrogant. Pas qu'une idée de gens.
Suspend. C'est moi qui en charge.
Ou qui en charge? Moun sort. C'est pas pour nous pas même arriver là. Qu'on a vu pour chef là.
Ça, c'est comment il est. C'est moi pour décider ça qui pour arriver. Moi, besoin de docteur. Est-ce que nous pouvons aider ou bien nous mettre à aller?
On va pas du temps. Docteur fait bébé mal. Même vous l'a fait mal.
Il y a un pile moun là.
Ça va, notre carte.
Docteur Yvon.
Ma fille, pas moyen.
Moi, vraiment besoin d'aide. Vous avez dans les mêmes conditions que j'étais avant. Gardez-le pour moi, tant pis.
Astrid, comment ça se fait? Vous avez fait mal? Vous avez flou? Est-ce qu'on a avant tout fait mal?
Moi, j'ai fait mal. Moi, pas trop clair après la crise là. Mais auparavant, tout le était normal. Moi, j'ai senti ma forme. C'est ça que je ne pas comprendre ce qui se passe là.
Chérie, il a assisté à sa maman. Depuis l'autre jour, elle a pris pour tout un peu.
D'accord, c'est ça. Faut que moins dès que je suis disponible, je vais retourner.
Mais c'est une urgence. Nous ne pouvons pas attendre encore donc là.
Bon, tout le monde qui a c'est urgence. Par exemple, le médecin qui travaille, c'est moi seul qui est disponible. Donc, nous vraiment travailler sous pression. Vous mettez une petite patienter, je vais retourner dès que je viens.
Mais les sont bien en crise. Je promets qu'elle est sérieuse. Moi, vraiment inquiété, docteur.
Ok.
s'il vous plaît, restez là, moi le côté docteur.
Ma fille, qui ça tombé comme résultat? Qui ça barre ça veut dire?
Pas besoin d'inquiéter Junior, docteur vient là un petit moment.
Junior, mettez ça là. Appareil ça fait pour contrôler la tension monde. Lumière où ça nous est là indique que tension artérielle en pile.
Moi connais ça lié. C'est moi-même qui a tripoté en pile. À cause de bébé, il fait tension artérielle monter très haut.
C'est pas stress qui cause maladie ça attaquer monde. Astrid, condition là-dedans, les pré-eclampsie. C'est une situation qui menace la vie si toutefois elle pas traitée. Et nous pensons que si grossesse la continue, la représente un risque ni pour vie pas ni pour vie pas bébé. Donc meilleur choix d'aka faire dans cas ça, c'est faut accoucher Kounia là.
Kounia? Mais il n'est pas trop bonnet.
Mais bébé a pas gain pile temps dedans.
Normalement, tout le monde a dû passer plus de temps dans votre maman. Mais à cause de tension artérielle qui a monté, placenta a mal fonctionné, bébé a doit mourir avant même que le fait.
Mais comment faire qu'on ait que ça a bien marché? Nous pas le faire bébé a mal, ni astrid tout.
Bébé a besoin de support, en plus de soins que nous-mêmes nous avons, mais le meilleur choix que nous avons fait là pour aider, c'est faire accoucher dans le moment ça.
Pre-eclampsie, c'est une complication grossesse qui est grave, qui peut affecter quelle que soit la grossesse. Il peut représenter un danger, ni pour maman, ni pour petit plateau. Il est important en pile pour toute femme enceinte qui va prendre soin prénatal pour minimiser le risque.